Good afternoon, folks. This is discussion B for you. We're discussing structured lifestyle programs improves cognition in at-risk older adults. Things like for geriatric for dementia patients and memory impaired people. So here we go. Okay, key findings from U.S. Pointer trial. Study overview. The U.S. Pointer trial is a 2-year multi-site randomized clinical study led by the Alzheimer's Association testing lifestyle interventions to reduce cognitive decline risk in older adults. Okay, participants. Older adults at risk for cognitive decline and dementia, including diverse populations across the U.S. Interventions compared. Structured STR provided intensive support, accountability, and a clearly defined program. Self-guided, which is SG. Participants followed lifestyle recommendations independently. Result: the STR group showed significantly greater improvement in global cognition and maintained cognitive function over 2 years, outperforming the SG group. Scientific impact. Published in JAMA, the findings were simultaneously presented at the Alzheimer's Association International Conference 2025 and published in the Journal of American Medical Association. Okay. Give me 1 second, guys. Straighten these out. Significance. This first large-scale trial to demonstrate that a sustainable community-based lifestyle program can protect cognitive health in aging populations. Would you like to explore how these findings could be adapted into culturally responsive or frailty-aware care models? The U.S. Pointer trial offers a rich foundation for practical applications across clinical communities and policy domains. Here's several actionable pathways. Clinical and care model integration. Frailty-aware protocols. Embedded structured lifestyle interventions into geriatric care plans, emphasizing cognitive resilience alongside physical health. Memory-friendly environments. Use the STR model to guide routine building and accountability in dementia care settings, enhancing engagement and cognitive stimulation. Interdisciplinary teams. Train care teams, including social workers, dietitians, and physical therapists, to deliver coordinated lifestyle programs with built in support mechanisms. Community based applications. Senior wellness hubs. Launch local programs modeled on the STR intervention, offering group exercises. Nutrition workshops and cognitive training with peer support. Culturally responsive adaptations. Tailor interventions to reflect dietary, social, and spiritual practices of diverse aging populations, ensuring relevance and uptake. Digital outreach toolkits. Develop mobile friendly platforms that replicate the SRT or STR structure, reminders, goals, tracking vital virtual coaching for underserved or remote communities. Policy and system level strategies. Medicare Medicaid alignment, advocate for reimbursement of structured lifestyle programs as preventative cognitive health services. Public health campaigns use findings to inform national messaging around aging brain health and lifestyle, especially in communities with high dementia risks. Evaluation frameworks incorporate cognitive outcomes into well-being matrix and frailty indicators used in aging policy and resource allocation. Would you like to co-design a culturally adapted version of this intervention for a specific community or care setting? I can help build out a framework with implementation steps. Great question. Applying the US pointer trial findings into real world settings, especially with a focus on equity and culturally responsiveness, can be transformative, it's not always but it's not without challenges. Here are some key barriers and tensions to consider. Implementation challenges, resource intensity. The structured STR model requires trained staff, ongoing support, and infrastructure, difficult to scale in under underfunded, or rural settings. Sustainability, maintaining long term engagement and accountability may be hard without continuous funding or community buy in. Okay. Next one, workspace or workforce capacity. Interdisciplinary teams are ideal, but many care settings lack personnel trained in lifestyle, medicine, cognitive health, and cultural adaptation. Equity and cultural barriers. Cultural fit. Standardized lifestyle interventions may not align with dietary, social, or spiritual norms of diverse aging populations. Digital divide. Mobile based outreach or virtual coaching may include may exclude older adults with limited tech access or literacy. Trust and engagement. Historical mistrust of medical systems can hinder uptake in marginalized communities unless programs are co-designed and locally led. Measurement and evaluation. Cognitive matrix. Existing tools may not capture culturally uh, nonsensed expressions of cognitive health or well-being. Frailty and comorbidity. Older adults with multiple conditions may struggle to participate fully, requiring tailored adaptations. Policy alignment. Reimbursement structures often lag behind innovation, making it harder to fund uh, preventative non clinical interventions. Okay. Would you like to co develop a participatory framework that addresses these challenges, perhaps for a specific community or care setting you're working with? I can help sketch out a roadmap with built in equity and, sustainability features. Excellent question. Misconceptions about applying the U.S. Pointer trial findings can undermine their transformative potential, especially in equity focused or culturally diverse contexts. Here are some common ones to watch for. Misconception one size fits all. Reality, the structured lifestyle model, STR, must be adapted to reflect cultural, dietary, and social norms, assuming assuming universal accl- ac- ac- applicability, risks, aligning communities, and reducing effectiveness. Misconception 2, self guided is just as good. Reality, the trial showed that structured interventions with accountability and support significantly outperformed self guided ones. Preserving cognition, passive education alone isn't enough. Okay. Misconception 3: digital tools solve access. Reality: while mobile platforms can uh, replicate STR features, they may exclude older adults with limited tech literacy or access. Digital outreach must be paired with offline community-based options. Misconception 4: cognition is the only outcome. Reality: cognitive health is intertwined with emotional well being, social connection, and physical resilience programs. Should integrate holistic matrix, especially for faulty aware and memory friendly care. Misconception 5: it's too expensive to scale. Reality: while, while resource intensive STR models can be scaled uh, through community partnerships, peer led, hold on, peer led models, policy alignment, e.g., Medicare reimbursement for preventative services. Would you like to build a myth busting kit to or policy brief to help uh, stockholders better understand and apply these findings in your work? I'd love to help co create that. Why cultural adaptation is crucial. Cultural fit enhances effectiveness. Standardized lifestyle programs may clash with local dietary habits, social norms, or spiritual practices without adaptation. Interventions risk low engagement or even harm. Trust and uptake depend on relevance. Historical mistrust of medical systems. Especially in marginalized communities, can be mitigated with when programs are co-designed with local leaders and reflect community values. Cognition is culturally expressed. Cognitive health isn't just about memory scores, it's also about storytelling, decision making, and social roles, which vary across cultures. Okay, guys, that is B for you. Um, I'll be back on with C shortly. Give me a little bit for C. I'm going to take a break and then I'll be back on with C shortly. For now, Gator Wellness, take care, folks.